Yeah, thank you very much, JP, for inviting me to this amazing conference. I mean, for me, I'm far away from my domain of specialty, medical science. And I'm very impressed of what I'm learning today. I'm learning a lot. And it's important for me, for my mission to teaching and training and mentoring my students at the university. So it's a lot of information. Thank you very much. I'm very impressed facing you, great expert on artificial intelligence. And I will try to give you my point of view. It's not a universal view that I'm going to go through, but just my point of view. So this is how we set up our thinking in terms of artificial intelligence, computational use, etc., in domain of medical science, the specialty of computer science, the big umbrella, computer science, and then we have artificial intelligence as a discipline, aims to create systems capable of reproducing human intelligence. So this is pretty, I would say, more than expecting, human intelligence. We have, again, in biology, we have animal intelligence, we have human intelligence, we have all this type of intelligence. And for the public, the message is very wrong. They think about artificial intelligence, something big. No, it's just like animal intelligence. They are pretty connected to nature. Artificial intelligence, pretty connected computer. So this different type of intelligence. So just about that in terms of communication with the public. And then AI connects a multitude of data, analyze it, and learn from the past and optimize it, okay? So this is what we are taking into account in our domain of medical science, collecting the data. Data have a value. We have to pay for the data. We have to pay for the people. I'm talking about the people, We have to pay for when you are bleeding somebody at the hospital and you want to do some kind of research, you have to pay for that. Data are valuable. Think about the global south. Our colleague was talking about, global south. We have to pay the data. So this is another kind of ethical approach. So all types, so just for me, and just to see my vision of artificial intelligence in terms of science, in terms of medical science, the first one is an AI performs specific tasks, okay? So we are using this, for example, at the hospital when we have this type of robotics. So reactive machine, the second step, you have this artificial intelligence with the machine, reactive machine, perform a specific task. Then the memory constraint AI, so historical data and pre-programmed information, make prediction and perform classification. So we are using this for years and years and years. We are using this type of memory constraint AI. And and my good colleague, we are using this for kind of hierarchized the different approach. We want to do in medicine on epidemiology. And then the machine learning. So this is a very simple term for me just to cover the huge progress you have made in this term of computer learn without direct instruction. Computer learn without direct instruction. And then, based on their experience, they progress. So this is another step I just want to mention. So very briefly, and this is important also in terms of, I think, biology in general. Remember the history. History is important. We are learning every day. Yesterday I learned. This is also history yesterday. We are learning about history. So 1921, artificial person robots were published by this guy from Czechoslovakia. Then 1929, the first robot in Japan. You see, we have the picture here. And then in 1949, we compared the computer and human brain. You see the step, you see the thinking, and I think it's good for us to remember that. 1958, the language, 1959, machine learning, 1959, 50, 60, 70 years ago. 1961 industrial robots, and the expert system. So this is, we work a lot in the expert system in my domain, you know, from mosquitoes to human, from disease, etc. Expert system was a fantastic development in terms of medical science, and the chatbot. And then we continued the deep learning, 1968, 1979, this Stanford code, and the deep blue IBM. So, and we all remember this, the chess computer with Garry Karpasov. Just this challenge he had with the IBM computer. One time he won, second time he won, and third time he lost, and after that, that's finished. The computer was the master of the chess, and he abandoned. So, in public health, so that's why I'm here, just to talk about public health, to talk about Africa, to talk about the global south, because this is, I mean, we don't focus on any type of any country, any region of the world. We have this global health approach, you know, and then we are trying to bring the most effective, the most advanced technology to the poorest, to fill the gap. So contribution and benefit, risk, and case study. This is where we go across. So contributions, so disease surveillance, important. We are using all the time, since I start working in the middle of the forest in Central Africa, we were using this for surveillance, collecting the data, improving the collection, treating the data, bioinformatics, etc. Health trend monitoring, so this is for the public health system, this is for the politics and stakeholders, just to show that the tendency. Environmental, so this is another source of data. Environment, we are connected with the environment, and we need all this data, including temperature, rainfall, etc. This is imperative, and we have to cross this data with the health of the people, with the health of the animals, with the health of the environment, the plants, etc. Crops, data analysis intelligence, health policy, so this is pretty classical, and decision support. At the end of the day, we are always collecting all this data from the environment, from the animals, from the humans, put this in together and decide what do we do. And again, one of the most important things is about communication. Trust, looking for trust to the people, communication. But you will see it's not only communication with the people, it's communication with you, with us, you know, this communication in terms of science, exchanging and working together. I will talk about that again. So just a few other examples. Detect and early detection. So this is really has been done with influenza, with dengue fever in Southeast Asia, with COVID-19, with Zika. I will go over very briefly about that. But this is what we are benefiting, the benefit of using AI, you know, be able to predict, be able to be ahead of the epidemic, of the extension of epidemic to the pandemic. We are not so good with the COVID-19. Now we are better. I hope we will keep the lesson. We'll learn from this lesson of this COVID-19. So again, in the analysis and in this disease surveillance, which is important, is to go to this social media, to all this production by internet and clean it. And this is back to you, back to AI. You know, we have to clean the information we are collecting from the public, we are collecting from the mass media. So, but it's important. We need that. Monitoring health trend, I mentioned that at the beginning, so that's pretty easy, and that's pretty easy for the computer to really analyze this data when we are feeding this data for a year, for 10 years, then we can really obtain some perspective on the trend of the disease. Do we have a risk or not? And when there's a plateau, there's no risk, and then we have a variation because the environmental data are going to impact this trend. Again, important to connect all these different data and source of data. Identifying emerging health. So that's another big problem, because this is more, when you don't know, you want to be able to identify before the emergence of the disease, before the problem. So this is complicated. And this is more the implication of the people. We have to really be in contact with the people and extract the information that said, okay, these people are at risk. We don't know exactly why they are at risk, but something is coming, complicated. But again, the mass of data need to be analyzed. And then we have the satellites. I was talking about environment, so I'm working with the NASA every week, every 2 weeks, We have the satellite data. It's huge, enormous. For us, as a biologist, much more than viruses or bacteria. It's extremely important, but we have all these data about pollution, about rainfall, about temperature, etc. So this is extremely important in public health. And then we have this public health alert and long-term mitigation. So yes, because at the end of the day, we want to mitigate the risk. So when we are informed of the risk, so we start having some kind of rules, regulations, say, okay, if this happens, this is what we are going to do. Data analysis. So back to the data. So this was more general. So data analysis, just what it's important, the social determinant. We were talking about several times about culture. People living in the city and people living in the rural area, nothing to do. They have a different interest. They have a different exposition to the risk. So this is also extremely important to determine the social determinant data, living condition, health activity, environment. So, and then to integrate this data, with data tree correction, so correcting the data, information, quantum computing. I learned about this morning also the potential of this tool to correct the data. And combining data. Also, it's important combining data at the beginning. We have to make sure that the data are separate. And then when there is a potential to aggregate the data, but this is complicated also. We have to think about, about combining the data, but it's extremely powerful. And then we can identify risk population, etc. And then we have this more technical aspect of artificial intelligence automats, analysis, and large-scale epidemiological data. So this is more technical approach, but yes, we can work in different countries, even in the global south. Evaluation of the impact on health policy. So simulation, yes. Intervention, yes. So that's not so complicated to understand that we can simulate, but we are very careful with the simulation, because the simulation today of emergence of the disease, it will be different tomorrow, because any type of factors can impact, the simulation. So we have to be very careful with the simulation. And some of you in the audience mentioned that yesterday about be careful about simulation, because this is the future, Evaluate the effectiveness of response and prevention. So we know that this type of recommendation, in particular by the government or by the responsible of the stakeholder responsible of public health, it's difficult to impose, So we have to make sure that we have this approach of trust, make sure the people are trusting. When we are talking, you remember, everybody remember what's about the masks wearing with the COVID-19. I mean, since Louis Pasteur and Robert Koch, we are wearing masks because we are working with microbes. This is classical. So there's no reason to say the mask is inefficient or even negative. So we need the public trust for that. And again, artificial intelligence, extremely important to have the public trust. I put this little example on the bottom here. It's just having this cohort, it could be a regional, it could be a national cohort, but we know the people and we know the risk of the people, and we are able to distinguish, to identify the risk and to identify the potential rise of an epidemic. And this is, so general consideration before the special, before the study, the study I just want to present also. Decision support, real-time decision. This is also some new approach, artificial intelligence can bring, because real-time decision, this is extremely important also. The time is extremely important in terms of public health in general and be able to stop any risk of epidemic. So this is the tools, dashboard for the forecast to inform to the public health policy, to the Ministry of Health, etc. So this is not complicated. And then allocation and planning. So again, we talked about yesterday and today about the allocation and planning of the resource. And this is also very important, where health resources are needed. Artificial intelligence, we have the experience, we have the past experience, COVID-19, the other Ebola virus, etc. We know when we have to have a stock of vaccine, when we have the hospital have an isolation ward in the hospital. So we know that. We have to be ready, and we have to allocate the resource in case of suspicion of epidemic of outbreak. And this is, again, it's a lot of data. It's 10, 20 years of data we have to collect and make sure we have the right decision for that. So I just put this little picture about the climate, about the climate, about flooding, about raining in the rural area. So all this data needs to be taken into account in terms of public health. The climate, so the climate number one, and the climate in the rural area here. The stakeholders need to know about that. And we know we have all this experience right now in the US here and in the other countries. They have really hit dramatically by the rainfall, particularly in Pakistan and other countries, very susceptible to the climate change. Communication. So I mentioned that communication, this is also essential. Demographic data, deliver personal public health message, etc. So communication, we are in a crossroad. The medical science are really in a crossroad of hard science, like you, and social science, they call that soft science, social and human science. And this is where we are now. We have to deal with this, and we are happy to do it, to analyze and improve the vaccination system in any type of population. And then we have the last one, the last concern of what artificial intelligence is bringing to public health, so disinformation, so we know about that in the recent months, years, and identify and report misinformation to the decider, public health holder, and accurate and timely correction. So that's another one. Misinformation, we have to correct. We don't have to forget or criticize. We have to correct, and then we have to give the counter information and the real information. And again, this is an important point. So, few examples, and this is, again, we are working with this. I'm working with this in Africa, in different countries in Africa. I'm working with these different approaches in Southeast Asia, in Asia, and so in South America. So this is real. This is what we are doing these days, Human and machines, so the risks now, human and machines, so training representative, risk of exclusion, and again, this is extremely important because we have this variety of the people, and variety of the culture, and the loss of human contact. So we mentioned that, some of you mentioned that also yesterday. So this is dehumanization, so in the communication. So the privacy and the data, we have a huge experience in medicine about the privacy of the data for the patient. Now we have to extend that to the family, and eventually to the village, and eventually to the city and to the country. So, but we have already this enormous experience of protecting the data from the patients. And now we have this the other level, protecting by cybersecurity. We have to protect the data of the patient and make sure these data, they are on the computer, but they are not in the internet, free to use. And the regulatory challenge, so that's, you are expert in this domain, so we have the legal and we have the ethics. And this is what we are focusing now in terms of medicine. So just to, in summary, machine and humans now, the slide before was about human and machine, now machine and humans, the data, quality, reliability, accuracy. This is our job for the past 200 years. Algorithm, though this is new, accuracy, validation. I insist on the term of validation of the algorithm. The obstacle, so this is when the data are bad, so we have to make sure that we understand and we can correct, and the system reliability. So this is two domains. We are not expert in our domain, so this needs your expertise to help us to adjust this type of accident, I will say, for now. But the solution is human expertise. We'll always decide. Human expertise will always decide human expertise. This is the two key words in this domain for us. Few study cases, so give me the time, I'm good?
A couple more minutes.
2 minutes. So this is what the tools we are using. This is the tools we are using everywhere in the world, you know. The predictive surveillance, we are using Blue Dot. Early warning system with health map for CDC in Atlanta is using this for years and years and years. And it's working very well, and it has been proved it's effective. Public health system, tools for forecasting, drones now, we are using drones. I mean, it's huge, and then these drones are not just flying. They have information, they know what to do, exactly where to deliver, at what time, and regarding the weather, with the situation, the conflict, local conflict, very often, it's using drones. Telemedicine, new one, so very efficient and very effective. So this is a few examples, the Zika epidemic for the Asian internet, and the internet showed that the Brazilian epidemic were undetected for months, so we were able to see that using the mass media, we can detect the risk of an epidemic with AI before the epidemic arrives, before the 2 or 3 cases in the city. So this is, again, a fantastic result, you know. COVID-19, AI showed that the 1 week earlier lockdown could be saved 20,000 lives. This is coming to the European country also, you know. If we think about do what the scientists are telling you, so you are saving people, saving lives, you know. The lockdown 1 week earlier, 10,000 lives. This is in the US. And that was calculated by the INSERM in France. So cholera again, we know that the cholera in Mayotte was a catastrophe also. That's a major role was the cyclone, so environmental factors, and the migration of the people. In the same time, we have a huge migration from different islands around Mayotte, and we have this huge cholera outbreak. And again, we need to collect all this data. So I don't want to go too much into this example. This one are more attractive. You know, we are doing this Blue Dot for new report. We are using airline ticketing also. When we have, this is another source of information for us in public health. You know, make sure we know the people they are on the plane, where they come from, where they are going, and if they are come from an endemic area, etc. The Zika virus was a big example of using artificial intelligence because we were able to identify the ecological niche of the mosquitoes, the first case, the temperature, and then we were able to, in particular in South America, to really to map the risk of the Zika virus extension. The vaccine, just a few words on the vaccine. So accelerate AI driving multi-omics. So this is in fact We are not with the people, we are with the molecules, the molecular approach, protein and genetics, accelerate epitope mapping, reduce the discovery, predictive analytics. So this is also a huge advancement in terms of public health because we can distribute, is much more easily this vaccine and much more efficiently. CEPI is working in the questionnaire for epidemic preparedness innovation. It's working against the Nipah virus. So probably most of you don't know the Nipah virus, but it's a higher risk for a global risk in terms of public health. Now it's in India, in Bangladesh, and several other Malaysia, they have been hit by the Nipah virus. So it's a priority to have this vaccine ready when we need. We don't need it now, but we need it. We will need it soon. So the COVID vaccine, everybody knows about Moderna and Pfizer, how fast they were able to adapt. We have 16,000 different mutants. So we have to identify among these mutants which one is going to be the next COVID-19 Omicron or something. So this is also artificial intelligence. Telemedicine, so I'm finished with this. I installed this, you can see these boots. I installed these boots in the middle of Central Africa in the forest. They are working, they are autonomous. They are sending the information to the cloud, and we are collecting all this information. And then we have artificial intelligence managing this type of things in the middle of Africa. So it works. It's not joke. So it's really, and we can take about now 60 or 70 vital data in one person in a few minutes. So this is also huge progress for the Global South. So I talk about the spatial data, so we water pollution, Rift Valley fever prediction in South Africa, etc. So this is really a classical thing. So preliminary conclusion, AI today, an evolving powerful tool for the public health in general. I'm talking about public health. Depend on transdisciplinary technology, caution with ethics and regulations. So transparency, mastering the bias, standardizing the protocols, approach with human intervention always, and a robust AI infrastructure. So I just want to insist on this transdisciplinary approach. I was talking at the beginning, the purpose of the multidisciplinary. No, we are now in the transdisciplinary approach. We want to talk with you, and you have to talk with us, just to exchange and to go to the same objective with the same tools and the same goal. So transdisciplinary approach, I think this is essential for the application and use of artificial intelligence. Thank you.
So I'll ask a question, then I think we have time for one more. So you lived for, and worked for many years in Central African Republic. And so if it would, one of the shorter longevities of population and fragile economy. So if the Minister of Public Health, Minister of Health asked you what your recommendations would be for Central African Republic and for his ministry and for the Pasteur Institute in Central African Republic, what would you say?
If you ask me for recommendation regarding the application of AI,
yes.
I hear one of you said yesterday about the leadership. So if we want to do that, we need a leadership at the Ministry of Health, and then at the Ministry of Agriculture, and then at the Ministry of Information. We need a leadership. And then if we have this, then it's not too complicated, because in Africa, most of the places in Africa, in South America and Southeast Asia, we can work with the cloud. We have this internet system, so we can connect. We are connected, and the people are connected. I mean, I was in Africa in 1979. I started. My first computer was a little IBM with I forgot the name of the spreadsheet in that time. It's black and white, fantastic. And then we have this in Bangui. at the very beginning in 1979. And then, so we can really use all this technology. We can bring this technology, and it needs to be robust, reliable, but yes, we can use it and we can work with it. And this telemedicine we are working in Caribbean island, also in several islands. We have these boats, for the people, autonomous boats for telehealth medicine, so it's work also.
Thank you.
Yeah, I have a question. Both of my kids are in medicine, and they are all using now open evidence. I would like to hear your opinion or your position on the more usage of open evidence. So the medical community, they're now consulting with it, and it's LLM, it's AI based. So what is your opinion about open evidence?
So number one, what do you mean by open evidence?
The open evidence, it's a model.
Yeah.
Like they consult with it. Like if they have a case, they'll just check it.
You are talking about the software.
Yeah.
Yeah. Okay. So because open evidence in science for us, it's different,
Yeah.
So there is application of.
I think it's the name of the software that's
okay.
like LLM.
So talking about the software, no, I think I'm pretty positive with this. I'm talking with my student to using this Google, ChatGPT, any type of resource on the internet. They can use it, but they have to correct it. Yesterday, 2 days ago, one of my students, she was presenting a picture, and the picture with the title, and the title was totally wrong. And I asked, where did you got the picture? She got the picture in the journal, scientific journal, peer-reviewed journal. And the title of the picture was wrong. And this is what artificial intelligence. For me, it's easy to detect artificial intelligence these days. So using this software, yes, I encourage them to use it, but make sure they are evaluating and they are correcting if needed.
Okay.
Because we need time. We need time to make sure that all these tools are effective and reliable.
Okay, thank you.
Like a vaccine, I was listening to the radio this morning about this people death for the COVID-19 vaccine. So they are saying people are dying, etc. The FDA is going to go back, etc. So this is one. And then I was listening to the scientists. They said, no, there is no more deaths with the COVID vaccine than the rubella, measles, or smallpox. So we have a situation. So we have to correct the data all the time. And I hope you will help to that.